The following podcast is part of a certified educational activity titled Winning Gambits Against AML, Guidance on Advances and Medical Breakthroughs with Innovative Targeted Strategies. Access the entire activity and complete the post-test at peerview.com/KEE860. Downloadable slides and practice aids are also available.
Okay, well, thank you everybody for being here. Okay, so we want to keep it nice and interactive. So we're going to be having AML-focused symposia, which at ASCO is, always not the majority, but the few, the strong. So we're going to be discussing acute myeloid leukemia, and the title here is Winning Gambits Against AML. I was telling Jessica, Gambit is my favorite character in the X-Men. So if you don't know, you guys are too young. But yeah. See, there you go. Gus is like, I don't know. So you can look it up. Very powerful character. So this is our panel today. It's myself, Dr. Jessica Altman, Dr. Gus Issa, and Dr. Alice Mims. So there have been many drug approvals in acute myeloid leukemia, actually just in the course of the last 7-8 years, from 2017 to 2025. It's kind of like a golden era of AML. I always say this is kind of like how myeloma was in the early 2000s, where you had a lot of drugs emerging, but in the end, the cure rates will take time as we move these into the frontline MRD setting, optimal use, because the single agents, they may meet regulatory endpoints, but the median improvements are not yet outstanding. But these are good drugs, and now we're moving them into combinations, and it is great to have these effective therapies now to work with. And I think we will see more in the near future, especially in terms of menin inhibitors and maybe eventually some of the antibody drug conjugates to CD123 and cell therapies, but those will take a little longer. So now, despite the progress, I think the sobering fact is there is still a lot of work to be done. If you look at the SEER database publication 2022, I think it was, the 5-year survival of newly diagnosed AML is still only 35%. So it's still not in the 70-80% as myeloma and CLL and others. So we still have a lot of work to be done there. And also what we see is there's a lot of patients who still are not getting treatment. This is probably from a few years ago, and hopefully this gap is getting smaller and more people are getting treatment. But again, in 2023, when this data was presented, they showed that still 39% of patients, and this was a big population study, 5,000 people in the United States, and almost 40% are not getting any treatment. I really think this is not ethically the best thing at this point, and we really need to push, because we have tools now, targeted therapies, venetoclax, low-dose HMA, that unless somebody's really frail or old, we should not be seeing a 40% group that is not getting treatment in the frontline setting especially. So the goals today are going to be to discuss the emerging evidence. We're going to talk a lot about targeted therapy, because that is where the successes have been achieved to date in AML, along with BCL2 and antibody drug therapies. And then we're going to try to individualize AML management using some of the targeted therapies and how best we incorporate them, focusing not only on efficacy, which is important, but also safety. And very importantly, and I think this will be a key thing in the next 3 to 5 years, like has been in ALL and myeloma, the use of MRD, and especially molecular NGS-driven MRD, to make key treatment decisions, when to escalate treatment, when to do transplant, and more equally importantly, when not to escalate and when we can avoid transplant and other measures. So we're going to cover a lot of that going forward. And then thanks to the HealthTree Cure Hub, this is a group that has been working very closely with many of us in the PeerView, and they have the healthtree.org portal that I'd recommend if you have the chance to check out. And really, they're collecting a lot of data from various different EMRs and electronic records across multiple different hospitals, with the idea being to have kind of patient-level data that we can then mine into and have available to have kind of real-world expectations, synthetic cohorts, things of that nature, which will become very important, because really, as you go through the data, you'll see there's no way we can do 500 randomized study for every question. We're going to have to find more effective and real-world situations to get answers and move forward. And hopefully the HealthTree data collection will help with that effort. So this is some of the key points with the HealthTree. They've already done a lot of work in myelofibrosis and MPN, and hopefully the same is going to be built in acute leukemia with the help of many of you in the room and many of us on the stage here. These are some of the topics that were recently covered, and this will continue to be built. So it will become like an online patient and physician access portal for emerging new hot topics, drug approvals, etc. in acute myeloid leukemia. And with that, I'm going to turn it over to Dr. Altman, my good friend and colleague, to start with the exciting data in the FLT3 mutated AML. Thank you. Jessica.
Thanks, Naval. Hi, everyone. Since I'm the only one from Chicago up here today, I want to welcome all of you to my beautiful city. Thank you for being here and coming to try to spend some time and learn a little bit and discuss acute myeloid leukemia. It is always this beautiful in Chicago every single day, even in February. So I've been tasked with talking about patients with FLT3 mutated acute myeloid leukemia. There are still a number of pressing questions in this space, and I thought we would start by thinking about a particular patient. So David's a 58-year-old gentleman, newly diagnosed acute myeloid leukemia, presented to the emergency room with fatigue, headache, and shortness of breath. He had 90% blasts in his bone marrow biopsy when that was eventually done, and you find him to have a performance status of 1. No real comorbidities. His creatinine is 1.4, but you think maybe that's due to a little bit of tumor lysis and a little relative dehydration. The bone marrow biopsy is conducted, and NGS shows a FLT3 internal tandem duplication mutation and NPM1 and presumably normal cytogenetics. So questions that we think about for folks with newly diagnosed FLT3 ITD mutated AML is what is the significance of an ITD versus a TKD mutation? And what options are we choosing for induction and then consolidation once the disease is in remission? And really kind of now we have new data regarding what does the quality of the remission and the MRD status, how do those two things inform our decisions about post-transplant maintenance and even in general, the decision whether or not to pursue transplant to begin with. So let's try to attack some of these questions. So FLT3 mutations generally come in 2 varieties, the internal tandem duplication mutation and the tyrosine kinase domain mutation. ITD is more common, happens about 25% of newly diagnosed AML patients. There is a higher prevalence in individuals who present with a higher white blood cell count, higher prevalence generally in younger patients because of the association with NPM1 and normal karyotype. It is associated, most of us still believe, with a poor prognosis. There's a little bit of data that we'll talk through as a team that it may not be as poor, but has a higher risk of relapse and really a high proliferative rate disease. An additional group of patients have a tyrosine kinase domain mutation. It is not so much that the effect on prognosis is unclear, it's kind of just intermediate. It's neither here nor there in terms of impacting prognosis. The current recommendation for individuals who are eligible for intensive chemotherapy, so appropriate to receive intensive induction chemotherapy, those folks with a FLT3 mutation the recommendation is to receive standard intensive induction chemotherapy, what we refer to as 7+3, with either midostaurin if the disease carries either an ITD or a TKD, or quizartinib with 7+3 chemotherapy. Quizartinib only targets the ITD mutation. Very recently, quizartinib was approved based on the Quantum First data. I'd like to just call out that there is the importance of understanding MRD. So MRD, we're going to talk about throughout our session today. It's a key prognostic factor in acute myeloid leukemia. It's especially important right now in making decisions regarding the use of FLT3 inhibitors post-transplant, and we'll cover some of that. Standard PCR testing that you can get by just sending out from your hospital only detects the ITD at 1%. That is not sensitive enough for the evaluation of MRD. There is the utilization of a PCR NGS that is both sensitive and specific for the FLT3 ITD and gets us down to about 10 to the -4 to 10 to the -6 in terms of sensitivity. So I want to get in a little bit into the Quantum First data. So this is our newest FLT3 inhibitor approved in newly diagnosed acute myeloid leukemia patients. Quantum First enrolled patients age 18 to 75 with ITD, AML. The results of this trial led to the FDA approval of quizartinib in combination with intensive induction chemotherapy and consolidation. And the differences shown here, quizartinib led to an improvement in median overall survival from 15.1 months to 31.9 months. And this improvement in overall survival translated to about a 25% reduction in the risk of death. What I think is particularly interesting about this study is the overall survival improvement was restricted to individuals under the age of 60. There is not a survival advantage to those individuals treated on study between 60 and 75. So quizartinib is not the only FLT3 inhibitor that has been studied recently in combination with chemotherapy for adults fit and appropriate for intensive chemotherapy. The other agent is gilteritinib, which is currently only approved in relapsed and refractory FLT3 mutated AML. So PreCog 0905 was conducted we have the first readout at this year's ASH. This study was a combination of either midostaurin or gilteritinib with standard intensive induction chemotherapy and consolidation. Gilteritinib compared to midostaurin resulted in a CR rate of 86%. A CRC rate, I apologize, of 86% compared to 72%. The primary objective of this study was to assess the MRD response after induction, and there was not an improvement with gilteritinib over midostaurin for the MRD CRC rates in after induction therapy. So about 40% of individuals who received gilteritinib had an MRD negative CR compared to 47% with midostaurin. So this is intriguing, and why are we finding this despite the improvement in CR rate? So I believe strongly that longer follow-up is needed to determine the impact on survival, number one. So survival is critical. This trial, the primary endpoint was MRD negative CR, not survival. But what we know about is for individuals who we have post-consolidation MRD assessment, that there was a conversion rate that was higher in the gilteritinib arm versus the midostaurin arm. So 83% of patients on gilteritinib versus 44% on patients on midostaurin converted from an MRD positive CR post-induction to an MRD negative CR post-first consolidation. So perhaps, and I think we'll see what my colleagues believe, that the assessment may have been done a little bit too early on this study. The gilteritinib compared to midostaurin is being studied not only in the U.S. PreCog study, but also by the HOVON group. So this is a randomized phase 3 study, a larger study, with an endpoint of overall survival. And 777 patients with newly diagnosed AML or high-grade MDS with a FLT3 mutation eligible for intensive chemotherapy are being treated on this study. And we await those results. So as we talked about, one of the pressing questions in AML in general, and particularly in FLT3 mutated disease, is do we need to proceed with stem cell transplant? Are there patient populations where we can safely avoid stem cell transplant? There's emerging data from Othman and colleagues that in individuals with NPM1 mutations, that if the NPM1 mutation clears, that stem cell transplant may not be required. This is true, according to this data, in individuals even with a FLT3 ITD mutation. So if you look at the first Kaplan-Meier curves, in individuals who are MRD positive post-induction, there is a benefit of stem cell transplant based on this retrospective data by the red curve going to stem cell transplant in CR1. However, for those who are NPM1 MRD negative after induction therapy, this data suggests that possibly stem cell transplant can be deferred. The I think one of the more interesting recent advances in FLT3 mutated disease is assessing the role of FLT3 inhibitors post remission therapy. So, for individuals who have undergone stem cell transplant with a history of a FLT3 mutation, there is a benefit for individuals who are MRD positive before stem cell transplant or after stem cell transplant receiving gilteritinib. So, a large transplant cooperative group study that answered that question. There's an improvement in relapse-free survival only for those individuals who had the identifiable presence of MRD before or after transplant. That benefit did not carry over for individuals who are MRD negative by FLT3 PCR. For individuals with a history of FLT3 ITD mutation who received a FLT3 inhibitor with induction and consolidation and are not planning on going to stem cell transplant, there's also an NCCN recommendation for the utilization of quizartinib for those with a FLT3 ITD mutation after the completion of all therapy. If individuals have a TKD mutation, midostaurin can also be considered. Okay. So let's get a little bit more into quantum first. Remember, this is the quizartinib study, quizartinib versus placebo. This slide demonstrates that individuals receiving quizartinib had a longer overall survival, even if they didn't undergo stem cell transplant. So there's a benefit with quiz whether folks undergo stem cell transplant or not. And this led to the FDA approval of quizartinib for maintenance monotherapy following consolidation. I've already alluded to the Morpho study, which gives us a little bit more granularity for what I showed on the prior one of the prior slides, that the any detectable MRD by the ultrasensitive PCR has an improvement in relapse-free survival with the addition of gilteritinib maintenance compared to placebo. And the curve on the right demonstrates the lack of improvement of relapse-free survival for individuals who are MRD negative. So let's get back to our cases. Now, what if David was not in his 50s, but in his 70s? So David now has aged 2 decades and 5 minutes, which is a little scary. But David is now 76-year-old with newly diagnosed AML, presents with the same symptoms, has a performance status of 1, and is also diagnosed with FLT3 ITD mutated AML and an NPM1 mutation. So in this patient, the things that we think about when we're encountering David in our clinic or in the hospital is lower intensity therapy an option for this patient, or should he be getting something like 7+3 and a FLT3 inhibitor? And what is the role of FLT3 inhibitor based triplets? So Nick Short and his colleagues at MD Anderson, and it's always a little embarrassing talking about MD Anderson data when I'm flanked by my MD Anderson friends, but I'm going to try to stumble through it. Nick and colleagues did a really nice study now published in 2024. So we'll have a little bit of follow-up data as well. But in newly diagnosed patients with a FLT3 mutation, they treated both ITD and TKD patients, that the triplet regimen of azacitidine, venetoclax, and gilteritinib led to a CR rate of 92%, with, very interestingly to me, an 18-month overall survival of 72%. And 65% of evaluable patients became MRD negative by FLT3 ITD PCR, which is remarkable. I'm showing you on these curves both the relapse-free survival and the overall survival in these patients. We have a little bit more updated data from ASH of this year that now shows a 2-year overall survival of 61%. So the 18-month to 2-year overall survival decreased a little bit. But when you look specifically at the FLT3 ITD patients, 2-year overall survival of 57%. I would like you to compare that to the standard of care currently for these individuals, which is the VIALE-A azacitidine venetoclax data. So CR rates of 32% versus 82%, pretty impressive difference. Median overall survival of 14 months versus 28 months. So again, a doubling of overall survival, a more than doubling of CR rate. But what's most striking to me is the 2-year overall survival difference, specifically the ITD patients, which we talked about as having a worse prognosis, of a 20% on just standard azacitidine and venetoclax versus 57% with the addition of gilteritinib. Pretty impressive. Good job, guys. All right. So
Gambits.
Gambits. So this emerging data has led to the development of a couple of clinical trials that are ongoing that I'd like to take a moment to mention. The first is the MyeloMatch program, which has multiple arms and is a match-based program. If you're not familiar with it, please find me later because there's really few things that I like to talk about more. Don't tell my children that. But so this is a study that I'm particularly interested in, compares individuals who are not appropriate for intensive chemotherapy to receive either standard azacitidine and venetoclax or 2 different ways of receiving azacitidine, venetoclax, and gilteritinib, either concurrent from the beginning of day 1 or the addition of gilteritinib a little bit later in the treatment course. This is ongoing, early days in accrual. Another study that Dr. Daver and I are also particularly interested in is Viceroy, which is a company-sponsored phase 2 study with the initial goal of optimizing the dosing combination of azacitidine, venetoclax, and gilteritinib. And accrual is ongoing, but we're getting there. So look for some more data coming soon, hopefully to a meeting near you soon. So I'm just going to provide a little bit summary overview of FLT3 inhibitors. And these slides are really there for your perusal in terms of the safety agents. I'll just note that midostaurin does have a risk of pulmonary toxicity, so patients should be monitored for pneumonitis or interstitial lung disease. And likewise, gilteritinib's most common side effects include transaminitis, myalgias, and there is a risk of QTc prolongation, which in clinical practice is actually very mild. Risk of differentiation syndrome, really, as you'll see throughout our talks with many of these targeted therapies due to their mode of action. Likewise, quizartinib has the risk of QTc prolongation and risks of fever, diarrhea, and neutropenia. I would like to note, and please refer back to this, that the dosing and induction and consolidation is different than the initiating dose in maintenance therapy and then the later dose after day 14. So I'm going to turn to Dr. Daver to walk us through these cases again.
Okay, well, thank you.
Thanks.
Thank you very much to Dr. Altman. So we're going to kind of go back to these cases and now, in the 10 minutes or so we have, kind of actually see how we will treat them in our clinics, because I think a lot of us know the data, but how do you apply it, I think, is always a little bit trickier because no one patient fits the exact criteria of the trial. So let's take this younger patient first. 58-year-old, as Dr. Altman presented, newly diagnosed AML, fatigue, headache, dyspnea, comes in with a high blast percentage. So one of the things is when you see such a high blast percentage, we always are thinking FLT3, KMT2A, RAS, some of these very aggressive phenotypes. And yes, indeed, this patient had a FLT3 ITD, and about 40 to 45% of them have a co-occurring mutation, NPM1. And this patient has some minor creatinine issues, not severe, but when you have such a high blast and high white count, you can see a little bit of spontaneous TLS and other issues. So I think for this patient, let's say this patient is in your emergency room, Dr. Mims, and you're called to see the patient, white count is 55,000, and you see these labs, like what are the first things you're thinking about for this patient to get the ball rolling?
So for the first things to get this patient going, I think you want to make sure that they're not having, tumor lysis, trying to calm down disease from that standpoint, any leukostasis symptoms that might need urgent intervention, and you may not have time necessarily to have all of these results come back.
Exactly, yeah. So you're right. So I mean, exactly. We'll admit this patient and hydria if needed, some fluids and echo and all of the basic PIC line. A lot of these things people don't talk about, but that's usually what happens on day one in the emergency room and admission. Sometimes ICU needed for monitoring, a Rasburo case for tumor lysis. So let's say all that's happened. And this was Thursday. Now we're 4 days later in our Tuesday noon meeting, Dr. Isa, where all the fun happens. And you're presenting this patient and you say, okay, now he's looking good. The creatinine is down to 1, healthy, fit, he's walking, no active infection. And I have 2 trials. I have a intensive chemo with the menin inhibitor, or I have an intensive chemo with the FLT3 inhibitor.
Always choose the menin inhibitor.
But walk us, and then I know Dr. Kantarjan say, but let's see what you say.
So in fact, there are 3 options.
Okay, yes.
Yeah.
Yes,
So-
you're right. There's 3.
Yeah.
And FLAG-IDA-VEN or
Exactly.
chemo-VEN. Yeah.
Exactly.
So how
So
do
I
you think about it?
I would also approach a little nuance about the FLT3 ITD burden. We tend to have a very sensitive FLT3 ITD assay. And in NPM1, if you sequence FLT3 enough, you're going to find some small clones. And I don't consider these the same. We're not talking standard. I'm telling you maybe how we would approach it at MD Anderson. So if it's a 0.01 FLT3 ITD, I am comfortable with either a FLT3 ITD high intensity, like a FLT3 inhibitor high intensity combination, or even a high intensity VEN combination. We have a great data with FLAG-IDA-VEN for these patients. I'm specifically talking about NPM1. I'm not talking about other co-mutations with ITD. Otherwise, this would be, the standard to do the addition of a FLT3 inhibitor, in this case, either quizartinib or midostaurin. And, someone 58, I would err on the side of high-intensity chemo.
Okay. Dr. Altman, what would your approach be for this patient? So let's say, because I agree, if the FLT3 is really, really low, which would be unlikely given the presentation with a high blast and probably high white count, how would you approach this patient? Let's say if you did not have a trial, how many days inpatient and, how
Sure.
do you start? Yeah.
Sure, thanks. So I'm going to assume this patient has a real FLT3 ITD based on the presentation and based on the result that will come back. And this is a patient that today, in the absence of a clinical trial, I would give 7+3 and quizartinib. And the patient would stay in our hospital until count recovery and likely a neutrophil count of 500 or getting close to 500 and not requiring platelets more often than every 3 days.
Yeah. And so, Gus, you mentioned quizartinib, midostaurin. Any thoughts, maybe Jessica, about between these 2 drugs, which one are you using both
Sure.
or are you using one, and how do you choose between those? Yeah.
Okay, so the easier answer might be, when am I using midostaurin? So the times that I am using midostaurin are for individuals 60 and older who I think are great candidates for intensive induction chemotherapy and who are not interested in a triplet-based approach on clinical trial at my institution. We try not to give triplets off of clinical trials. So that's the patient who's getting midostaurin at my center, or if they have FLT3 TKD mutated disease, because quizartinib does not work, maybe until we get a little bit more data. But right now, that's not the approval indication. So FLT3 TKD mutated disease or 60 and older, but we can talk about it's not like the data with midostaurin is that good with 7+3 for older than 60, but there's not a survival advantage for quiz. So that's a bit of a conversation. So I am using quiz generally for almost every individual under the age of 60 who's appropriate for intensive induction chemotherapy with a FLT3 ITD.
Yeah, we're doing this similar as for most intensive chemo-based, it's quiz added to the intensive chemo backbone. Very eager to see the gilteritinib randomized data with HOVON. I think that study's completed enrollment, so we'll hopefully see some of that data, and then we'll have to review and decide, how to select between them. We don't really use much mido. So about, 60 to 65, it's always the discussion, is the patient really, really fit? You have some who are very healthy, marathon runner, no comorbidity. We may do intensive chemo with quiz and then transplant. But then, yes, if they're starting to look frail, above 65, comorbidities, then usually we have a number of trials and probably will go on a triplet-based approach. I think it's important there also to highlight that with quiz, the above 60, there was no clear survival advantage. It wasn't worse, it just was not there. But I think with MIDO as well, there's some data non-randomized from Germany. So I think that population is just a tough population in general right now. Yeah, to look at.
In those patients, there's more at play than just their FLT3 mutation as well.
That's another factor, yeah. So Alice, so to MRD assessment, what are you doing at Ohio State? When do you do these MRDs and what type of MRDs? And then also, how are you using it? Let's say for this patient, intensive chemo, end of cycle 1, would you check it, or when would you want to check it?
So I think what we're traditionally doing is checking like in vivo scribe, and we'll do that just with the sensitivity after they complete their induction therapy, after other cycles of intensive consolidation. And then, of course, if they're planned to move to transplant, then right before that, and then post-transplant as well.
Is when you so the in vivo scribe, just for some of you, this is in the US, the commercial vendor that has a very sensitive, potentially down to 10⁻⁻⁶, so 1 in a million, so very similar to ALL clonoSEQ, which is kind of like our gold standard for MRD today. And there is data showing from UK, from Australia, hopefully we will have similar data soon in the US being generated, that can predict for outcomes with transplant, without transplant, and potentially even those who go to transplant. So let me move to the next slide here, because I think they have some more questions. Okay, so there we go on the MRD line. So let's say this patient was MRD positive by a high sensitivity assay, such as a PCR-NGS, either by in vivo scribe or other RT-PCR approaches. And now he's in CR1, but after 2 cycles of intensive chemo, which is where Othman and colleagues and the Australian group also showed similarly, it seems to matter on outcome. So what would you do for such a patient today? Would you take him to transplant? Would you not take him to transplant? So let's take the easy one. Let's say he's MRD positive, 2 cycles at any level, 1 in 10⁻⁵. Gus, what would you do? Yeah.
Transplant.
Transplant.
I'm giving me the easy one, yeah.
And then post-transplant maintenance, right? Exactly.
I agree.
So now the trickier one, what would you do if this patient is 10⁻⁶, completely negative by FLT3 and NPM1, 2 cycles of intensive chemo? Your transplanter calls because, when they have a good candidate, they start pushing. Says, I have a 10-on-10 donor. I had an email like this 10 minutes ago. 10 minutes ago, I'm like, wait, I want to transplant him to next week. I'm ready, blue fuel. So Jessica, what do you do now? You say, yes, let's go, or?
Okay, so for this patient with a good donor, without comorbidities that you're describing right now, I would lean towards stem cell transplant. I think the Othman data is great. I think it's very encouraging. I look forward to more building on that. And what I can tell you right now is from that data, there is not a detriment for transplant. So it doesn't also really matter what I want, right? It's a conversation with our patients. We talk about the risks and benefits. I share the Othman data. I talk about where we are in the world with FLT3 mutated disease. And we share decision-making, right? The patient makes the decision and we counsel them.
Yeah, I think this is one of the areas where this is actually real, right? I mean, we say this, but many times, of course, we have something that is really better. I'm going to say do AZA-VEN, not AZA, right? But here, I think it's, and because one has to realize the Othman data. So what they showed, one, it's retrospective. Second, most of those patients do not have FLT3 inhibitors, so it's not fully contemporary. I still agree. I think that data will hold out in time as we have confirmation, but we don't have that. But the biggest thing is the EFS rate is quite different. It's 10 versus 40%. So if you ask a 40-year-old or 45-year-old, that, okay, we could do this, but there is a 40% chance your disease will be back in the next 3 to 4 years, and we could probably treat it because it's NPM1 FLT3 and get you in remission, versus I have a 10-on-10 donor, your post-transplant mortality is probably less than 5% at this age. Would you want curative approach? I think I don't know. If it was me, I might say, let's just get this done. I do not want to have this on my head for 5 years. So I think there's a little bit of a trick there where OS may eventually be equal, but can you just get the disease cured? And so I think that will be something in the future that we will have to look at as things move forward.
Naval, I think that's a great point. I think it's even more interesting as you're thinking about the 60-year-olds, right, who may not be as good a stem cell transplant, or the 55-year-old in another couple of years when their disease recurs.
Right.
So
no, I totally, and that's where we're, where we're starting to use this is like that 69-year-old where, okay, he has an 8 on 10 donor, and transplant is like, yeah, we can do it. And I'm like, well, he's MRD molecular negative. If the survival is similar, let's wait. And 60% of them are going to do fine. For the others, then we will take the risk. So I think the point we're highlighting here is there's a lot of nuance to how this PCR NGS data is going to be used, and it's not established, but it will be, I think, in the next few years. So now let's move for a couple of minutes to a more difficult overall scenario, right? In the young, yes, there are differences in opinion, and maybe practices in UK I know are different. They're actually not transplanting patients who are MRD negative, but in general, outcomes are hovering close to 65-70% long-term survival. Now we're talking about a group that 8-9 years ago, before Ven, the 1-year survival was less than 20%. Today, as we said, okay, it's getting better, closer to 35-40% with HMA-Ven, but we still need to improve on that. So let's say you had this patient, 76-year-old, and as Jessica outlined, we have the options. So how would you select? And again, I'll ask you guys. So if this patient was there and you have the options, HMA-Ven, FLT3, potentially HMA-Ven, menin, how do you choose the front line? And let's say the FLT3 is reasonable, 20% or something, not super high. Yeah. You have to be an independent observer. Yeah.
Yes, of course. So maybe I'll do my biased approach, and then I'll do my independent approach. So the science behind using menin inhibitors for targeting FLT3 is very good preclinically, where menin inhibition could affect transcription of FLT3 because menin inhibition affects MEIS1. MEIS1 regulates levels of FLT3. And in the single agent revumenib data, for example, we looked at with and without FLT3 co-mutations, and response rates are the same. But regardless, I would still be nervous about someone frontline with a FLT3 ITD that's a high burden of not using a FLT3 inhibitor. So I think we need more data with menin inhibitors, and maybe combinations of menin, just throw them all, menin, FLT3, HMA, Ven. Eventually, right? Yeah. But for now, my go-to would be HMA, Ven, FLT3 inhibitor.
Yeah. Any other thoughts, Dr. Alderman, Dr. Mims?
Completely.
Okay. All right. Well, hopefully with the ongoing studies, the Viceroy and the MyeloMatch, we will have more data to add to the data we have published now, and that will hope establish these regimens, for future use. So we have a couple of minutes. I'm going to turn it actually back to you, Dr. Altman, to close out, and then we'll get more questions.
We have just a couple of minutes. I'm just going to recap what we talked about. So remember David at the age of 58, the younger David, determined to be fit for intensive chemotherapy. In summary, our group, 4 of us recommend the use of quizartinib plus chemotherapy supported by the current evidence and guidelines. If his disease is in CR1 after induction chemotherapy, but MRD positive by PCR after induction and likely a cycle of consolidation, recommendation for our gentleman was to proceed to allostem cell transplant with the utilization of gilteritinib post-transplant based on morpho. But if in CR1 after intensive induction chemotherapy and consolidation and MRD negative, and uncertainty, there's continued uncertainty about the role of stem cell transplant. So we discussed this, that retrospective data suggests that transplant might be deferred if you're confident that the disease is MRD negative. And this is an area of active investigation, and to date, a really just important topic of conversation with patients, and likely something that would require multiple conversations over multiple visits with us and conversations with the transplant physicians. And again, this is an area where utilization of quizartinib maintenance after consolidation is supported by the data from Quantum First.
Let me take a couple of questions here. And one important thing also with the quiz maintenance. So in the US, as Dr. Altman was saying, the current label is for maintenance quiz after induction consolidation for a patient who cannot go or does not go to transplant, such as this patient. We would continue the quiz up to 3 years, and there's very strong survival signal there. Post-transplant, the study allowed it, Quantum First, but the FDA did not feel that the delta or survival advantage was as good. So in the US, It is not FDA labeled, but the NCCN does include it. And actually ex-US, I know it has been approved in UK and others. So I think quiz is definitely a great option for those not going to transplant, post-transplant. I think you'll have to look at the options and tolerability and decide. Let me ask you this question, Jessica. So does the choice of frontline FLT3 inhibitor matter for later treatment decisions? For example, should I consider maintenance with GILD post-transplant in a FLT3 mutated patient who received midostaurin upfront, or if quiz upfront? So I guess the question is, would you switch to GILD, or would you continue with quiz or mido? Yeah.
Great. So in the US, as Naval just mentioned, quiz does not have an approved indication for the use post-transplant. If you have access to it, for sure you can utilize it. I'm a big believer in the morpho data, and so even if patients had received midostaurin, certainly because that was what those patients were receiving, and then went on the morpho study, or quiz, I would likely switch to GILT post-transplant.
Yeah, I think the morpho randomized data is pretty strong. So at this point, that's kind of what we're doing for a lot of our patients. But yeah, many of them got sorafenib or mido before, so we'll have to wait and see with the HOVON data. So I think in the interest of time here, we will move on to the next session and love to introduce Dr. Alice Mims, who will be talking us through the IDH. Please, Alice.
So thanks, Naval, and hopefully I can excite you all with my most favorite topic, or most favorite mutation currently, IDH. And so we'll also start off with a patient case. So this is Susan. She's 66 years old, presents with newly diagnosed AML, has some comorbidities with chronic kidney disease, with a GFR of 50, performance status of 2, and then is found to have, with her genomic data, intermediate cytogenetics, and has an IDH1 mutation and a FLT3 wild type status. So to think about as we go along, some data in the IDH space in AML, what is the go-to strategy for initial therapy here? Is more intensive therapy an option in patients who are more fit? And so you have this patient, she wants to know what does this mean with this IDH mutation? And this was a large study performed by Dr. Sagner Lumley through data from COG, SWOG, ECOG, Beat AML, and they looked at over 3,000 patients total, and looked at different types of mutations. And for IDH mutations specifically, they found that across the age spectrum, they were in about 9% of patients. And the prevalence of that increases as patients age, where there's a prevalence of about 3% in pediatric cases and goes up to about 21% in patients who are older, so 60 or above. And all of these patients were treated with, for the most part, intensive chemotherapy regimens. And so they wanted to look at what the impact of IDH mutations had on survival outcomes, because the data has been a bit mixed. And so with looking at just presence of IDH mutation versus not having presence of an IDH mutation, there really was not impact on outcome. There was no difference between outcome survival data with IDH1 versus IDH2, or within the different subtypes of IDH mutations. NPM1 is a very common co-mutation that occurred in this analysis. About 50% of the IDH mutated patients had NPM1 mutations. And so they dug a little bit further into that co-mutational group. And so what they saw is that patients who didn't have an NPM1 mutation had worse outcomes. With an NPM1 mutation, those patients who were less than 60 years of age, so pediatric up to intermediate age, had improvement in event-free survival. And then for patients in both the pediatric and intermediate age group, which is 40 to 59, had improvements in overall survival, but not that AYA population. And then they also looked at, if you had this triple mutant status, what were some important mutations that could impact that favorable NPM1. And the first is FLT3 ITD, which showed in across the board for patients with overall survival, but not event-free survival, worse outcomes. And for patients with DNMT3A mutations, they looked specifically at patients with intermediate age, and those patients had worse CR rates, event-free survival, overall survival, and increased relapse rates. And so as the majority of patients with IDH mutations are going to be in that older population, it just highlights the need to try to better determine what type of treatments will your patient be a candidate for, and thinking about things like baseline geriatric assessments to think about fit versus unfit, and then also having accurate mutational testing and trying to have that back before you make a treatment decision, because it could impact choices for your patient. So the Agile study, I'm going to talk now about treatment choices in the newly diagnosed setting for patients who are not fit for intensive chemotherapy. And so the Agile study was a randomized phase 3 double-blind placebo-controlled trial that looked at comparing ivosidenib to azacitidine versus placebo azacitidine for patients who were not fit for intensive chemotherapy, either defined by age 75 or older, or had certain comorbidities like renal failure, pulmonary issues, cardiac issues, or just worsening performance status. And so the study had the primary endpoint of event-free survival, which looked at time of randomization to treatment failure, which was defined as either not achieving a CR by 24 months, having a remission, then going on to relapse, or death from any cause, and it was whatever occurred first. While the study was still enrolling, the Data and Safety Monitoring Committee actually reviewed the data and saw that there was increased death seen in the azacitidine placebo arm, and so they stopped the study early. And then this led to the FDA approval of the ivosidenib combination for this unfit for intensive chemotherapy IDH1 mutated population. And you can see here with the Kaplan-Meier curves that event-free survival was improved, as well as overall survival. And then there was updated data presented at by Dr. DeBottom at ASCO about 2 years ago that showed at a follow-up of 28.6 months, this persisted when seeing a median overall survival of around 29 months for the Ivo-Aza arm versus around 8 months for the placebo-controlled arm. And these are just, I think, impressive with the bar graph showing that at a year, 2 years, 3 years, that there's still a significant number of patients who are initially treated who are still alive, especially compared to the azacitidine arm. So the controversial question is, why don't you just treat these patients with a venetoclax-based regimen? Because we know that these patients do respond well typically to the venetoclax treatment, and why take the time to wait for the mutational status to come back before you're going to make a treatment decision? And so this is a pooled analysis that was performed by Dr. Pollier and colleagues that looked at patients with IDH mutations from both the phase 1b precursor study to VALIA and then VALIA patients, and specifically IDH1 and IDH2. And what they saw is that with venetoclax azacitidine with IDH1 mutated disease, the median overall survival was about 15.2 months with a 2-year overall survival of 42%. And I will state that these are small numbers of patients. For IDH2 mutated patients, the median overall survival was not reached within HMA-based approach, and then the 2-year overall survival was 60%. And so we're not supposed to do cross-study comparisons. This has not been studied together. We do have a current randomized study trying to answer this question better, the iData study, but I think this gives you a little bit of a pause seeing how well patients with IDH1 mutations did with an IDH inhibitor AZA-based approach. There's also a question of should we be combining IDH inhibitors with intensive chemotherapy? And this is there's been just some initial studies that have been completed, phase 1b, looking at combination regimens with either 7+3. That was presented by Dr. Stein a few years ago, which showed pretty good data with overall response rate, 77%, 12-month overall survival of 78%. and showed that the treatment was well tolerated. And so this has also been recently presented at ASH this past year of looking at combination with CTX-351 with ivosidenib. And this was a bit more of a mixed bag because it had both newly diagnosed and relapse refractory IDH1 mutated patients. And so there are only 4 newly diagnosed patients that were presented. All 4 patients responded. Median overall survival was 29.3 months. So more to come in this space. The phase 3 HOVON 150 AML study, which is looking at a randomized placebo-controlled trial with the addition of ivosidenib to intensive induction, consolidation, and maintenance therapy for newly diagnosed AML or MDS with XS+2 who are eligible for intensive chemotherapy, has completed enrollment. And so we're really waiting for the readout of that study to tell us if we should add IDH inhibitors to intensive chemotherapy. So now we're going to go back to our patient Susan. So Susan was treated with ivosidenib and azacitidine initially. She achieved a remission. She had a really nice remission for about 2.5 years, and then unfortunately went on to relapse. And so she's now 69 years of age. She still has her same comorbidities, performance status, has not shown any clonal evolution in regards to cytogenetics or mutational status. And repeat testing did confirm IDH1 mutation. And so some of the questions to think about are, what would you do next for this patient who had ivosidenib and azacitidine? Do you need to retest for an IDH mutation at relapse? Why might that be important? What if she had progressed after having a venetoclax-based regimen? So for the NCCN guidelines, how they're currently written for relapse refractory AML patients is there's a lot of splitting of patients based off of mutational status. And for IDH1 mutated patients, there are 2 options. Ivosidenib, which is the IDH1 inhibitor that has been approved the longest, and then there's also olutasidenib, which is a newer generation IDH1 inhibitor. And so just briefly, I was going to mention that for ivosidenib in the space, there were 124 patients treated on the dose escalation expansion study, and there was an overall response rate of about 44% and a CR/CRh rate of about 30%, and the duration of remission was about 8 months. I just think that'll be important as we're thinking this through for choices. Also of note, for that initial study for ivosidenib in the relapse refractory setting, we weren't standardly doing venetoclax-based regimens, and so it's not really well known about how patients will respond to IDH inhibitors now in this venetoclax HMA era. So there are some different retrospective studies that I'm going to just present briefly that are trying to answer this question. And so this first one is from Dr. Burestorff, where they looked at 53 patients who received either FLT3, IDH, or IDH2 inhibitors after progression on venetoclax. They saw an overall response rate of about 17%, and only 1 patient of the 17 who was treated with enasidenib responded and achieved a CRi. And so with midostaurin, sorafenib, ivosidenib, none of those patients had an objective response. Gilteritinib is not listed, you'll see for that. And for the 22 patients treated with IDH inhibitors, you can see that the survival curve is pretty dismal, which was a median overall survival of 3.6 months from the initiation of their IDH inhibitor. This other study by Dr. Khanna, which is retrospective as well with 4 U.S. medical centers, looked at 22 patients with AML, and again, the same mutations. And as you can see, there's very limited data here. For the 2 patients treated with ivosidenib, 1 patient achieved a CR. That duration of response was around 9 months. For 5 patients treated with enasidenib, 1 patient achieved a CR, 1 patient has stable disease, and then 1 patient treated with enasidenib plus HMA had stable disease as well. So we're not hitting it out of the park with this limited data. And this is, I think, a really interesting retrospective study from the MD Anderson group that looked at the sequencing of therapies. So for patients who either started off with an IDH-based regimen and then went on to receive a venetoclax-based regimen, how did they do overall in terms of median overall survival, and the reverse with starting a venetoclax based regimen going on to IDH inhibitors. And again, these are very small numbers of patients, but you can see if patients received IDH-based regimens initially, most of those patients went on to respond to venetoclax HMA. So the salvage response rate was about 88%, so 7 of 8 patients responded. 4 of those 7 were able to go to allogeneic transplant. For the venetoclax plus HMA initial start of treatment, which is depicted by the green, the response were less. The patients went on to IDH monotherapy, so 2 of 4 patients responded, 2 of 7 with an IDH inhibitor ven doublet or HMA doublet. But very interesting, I think exciting data is this response to the triplet regimen with IDH inhibitor ven HMA. And so in this small study, they saw 6 of 7 patients responded to this, and 2 patients went on to go on to allogeneic transplant. And so triplet regimens are being studied now in the upfront setting, so we'll see where those land for our IDH mutated patients with more data to come there. But overall, looking at from start to finish for these patients, the median overall survival for patients who initially started IDH-based treatment was about 47 months. Those who started then AZA initially, or HMA, was around 20 months. And then we don't want to leave out olutasidenib. That's we talked about ivosidenib for the majority of this talk. So this is a potent, highly selective IDH1 inhibitor. It's FDA approved just in the setting of relapse refractory IDH1 mutated disease. And so in the study where they looked at relapse refractory patients, they saw of the 147 patients who were eligible for analysis or efficacy analysis, the CR plus CRH rate was about 35%, and the duration of response for those patients was about 26 months and had an overall response rate of 48%. And then when they looked at survival outcomes, the median overall survival was around 11.6 months in all of the patients treated on study. But for those patients who achieved a CR/CRH, the median overall survival was not reached at time of this analysis. And the estimated 18-month survival was 78%, which is pretty impressive. So there's been presented a few different times some ongoing data analysis, and there is actually an abstract by Dr. Wang that's being presented here at ASCO this year. But looking at the 147 evaluable patients, overall response rates at 5 years were around 48%, CR/CRH were around 35%, median duration of response was again around 25 months for those patients who achieved a CR/CRH, and then median overall survival was 11.6 months for the total population and not reached for the CR/CRH responders, with 50% alive at 5 years, which again is pretty impressive. And what is being highlighted at ASCO this year is those higher responses, including the CR and CRH and greater survival in patients receiving olutasidenib was for those patients who didn't have as much treatment prior to initiation, so 1 to 2 lines of therapy versus 3 or greater treatment regimens. As this study occurred when venetoclax and azacitidine was more in the mainstay of treatment, there is data about olutasidenib responses in the post-venetoclax setting from the study. And so there were about 16 patients that were analyzed. There was a 25% CR rate, some lesser responses of CRH. A median time to CR, composite CR was around 2 months, and the median duration of composite CR has not been reached. So it is encouraging that patients may respond to olutasidenib after venetoclax treatment. Also, is there a role for olutasidenib combination therapy? So there was an arm in the study that looked at hypomethylating agents with olutasidenib. This is a pooled analysis and showed for patients a composite CR rate for all patients with relapsed refractory AML around 39%. If you took out the olutasidenib, that improves slightly to about 45%, because 31% of patients had prior IDH inhibitor therapy and 24% had the olutasidenib, 40% had prior HMA therapy. And the duration of response for patients who achieved a CR/CRH was around 14.7 months. So just some practical points around selection between IDH inhibitors and AML. Dosing's a little bit different with ivosidenib, daily dosing. Olutasidenib is twice daily dosing. Both have restrictions around meals to take into account. Ivosidenib does have QTc prolongation that can occur in patients, while olutasidenib has been shown to show some hepatotoxicity for patients as well, with about 5% of patients who had a significant hepatotoxicity having to stop treatment. And for both of these, differentiation syndrome can occur. That can range between about 10 to 20% based off of what study you're looking at. And just of note, if you are suspecting differentiation syndrome, and it can be hard to tell initially if it's going on, but if a patient's having a higher white count, increase in blasts, increase in neutrophils, if they have AKI, if they have lower extremity edema, pleural effusions, pericardial effusions, pulmonary symptoms with infiltrates, most of the time we would think about, unless there's a clear reason, initiating corticosteroids first while we're waiting to figure out what's going on. And then monitoring, and if it is differentiation syndrome, giving them time to resolve before pulling off the steroids, or if it ends up being something else, getting off of steroids more quickly. And so I think with that, I will hand it over to Naval.
Okay. All right. Well, thank you. Thank you very much to Dr. Mims. Okay, so let's kind of do similar here with the 66-year-old patient, newly diagnosed AML with IDH mutation now, and has minor CKD, PS is 2, so kind of a little bit difficult one, I think, here to think about in intensive. So we have the two low intensity options, right? HMA-IVO or HMA-venetoclax, and I think the big question here is how would you choose between them? Assuming you have the data available to you. So let's say you have a quick mutation test, you have the results ready. What is it today? Alice, you spoke about the data, but how do you choose them if you have these two options ready outside of trials?
So, I typically will talk to my patients about their two choices at hand. But some things that I take into account are there's less myelosuppression with the IDH based regimens. And so maybe some decreased toxicity from that standpoint. Then also seeing some of the long-term outcomes makes me a little bit more favorable to that regimen for the majority of patients.
Right. And then if you are starting with HMA-ivosidenib, how do you manage inpatient, outpatient? Do you admit these patients for a certain number of days? How do you approach that?
So, I think if the patient's presenting in the hospital, needs to be there for other reasons, that you want to initiate therapy, that's reasonable. I think for most patients, this can be done outpatient as well.
So if they're stable, once you started, you'll get them outpatient last 2 or 3 times a week and then continue that. So, Gus, any different thoughts here between the two options?
Well, I think the triplet is wonderful with
Sure.
IDH inhibitors.
Yeah.
Like, there's very little myelosuppression. Even if it's not a trial, I tend to do the 3 medicines. But, if we're imagining we're giving, between the two choices, I agree with what Dr. Mims said.
Go ahead.
Can I ask a question about that? If your patient is not going to be interested in stem cell transplant, do you still use a triplet?
Yeah.
And do you continue the triplet indefinitely?
Yes, but that's a very tough question. So we don't have a good MRD assay. So let's say they are NPM1 co-mutated, then maybe I would look at the NPM1, and there's the retrospective analysis from people who were able to discontinue ven, and those were, the NPM1s or the IDH, and had multiple times where their MRDs were negative, and maybe those can stop. But I have a 78-year-old who, when I first met her, had an MI because her platelet count was so high, and she got on the triplet, and now she's been 2.5 years on it, and she goes on cruises, and every once in a while I have to ship her the medicine. She's doing great.
Yeah, I would say there's a more nuanced answer as to how long. So, the way the study, because I just have a patient this week that we're transitioning from the triplet to single agent at 12 cycles. So the study says to do up to 12 cycles, and then you can do either the triplet or you can switch. I think this is the challenge, and this is the same, Jessica, with the FLT3 and probably will be with the menin, that I think it's very hard, and I do not believe this is how the triplets will be used, to do continuous long-term triplet. I think this will make it challenging. I think it's going to be more like they're doing in CLL and others, where you have an initial effective regimen without mucositis toxicity. You can give it to a 70-75. You will achieve a deep remission, and then some point, and that is harder, as Gus says, with IDH, because we don't have a good known prognostic MRD. But maybe in 6 months, 8 months, or 12 months, then you de-escalate. But that being said, and we didn't have the data here, but Courtney has recently published that data where we now have close to 80% 3-year survival in patients with a median age of 70, 71 years of age. So it does look impressive, and the HOVON is now starting a randomized study there. So we'll get some of that data. But I do agree, I think the next 2-3 years is going to be more about how much and who needs longer triplet versus which ones you just need 6-8 cycles and then you can de-escalate, right? And we're starting to look at those questions going forward. Okay, so let's take this same patient now who's 66, right? But has normal renal function and PS is 1, so very healthy 66-year-old is there now in your emergency room. And the question is, what are the options? Well, would you consider intensive chemo? I guess one option. Would you still say I'm going to do AZA-IVO or AZA-VEN or the triplet? And then if you would do it, is there any data yet to add an IDH inhibitor, or would you add venetoclax? What are your thoughts, Jessica?
Sure, thanks. I think this is a really challenging situation. I would have a long conversation with my patient about the outcomes with intensive induction chemotherapy with or without an IDH inhibitor. Again, that is not an approved indication, but Dr. Mims shared the data that exists. I think that if I were 66 with IDH1 mutated AML, and assuming no other mutations, it says it's FLT3 wild type, kind of depending on what else is in there. I think if it were me, I would have Dr. Mims give me AZA-IVO and with consideration of a stem cell transplant.
Yeah, I think, this is a tricky question, but these are the real patients, right? We see. And so what do you do? Because you have many options, not wrong, not right. AZA-IVO is, I think, reasonably correct, because you could say, okay, the performance status of any AML patient is borderline 1 and 2. It's kind of hard subjective. And AZA-VEN has reasonable data. Intensive chemo is an option. I do agree. The one thing that we're not doing at all, either Anderson, is off protocol adding IDH to intensive chemo. We have not done that, because if you look at the FLAG-IDA or CLIA-VEN, the IDH do quite well. Now, there's some updated data we're looking at where the IDH1 may not be doing as well as we initially thought with the intensive chemo VEN, and there may be a role if the HOVON study comes in. But yeah, I think this is a patient that either way, transplant is definitely where you want to go, and you could start with either option and probably get to transplant there. Another question, do any of you monitor NGS for IDH? And if you do it, is there utility to it? Do you have the test, Jessica or Alice? Or
So we do have high sensitivity IDH1 and 2 NGS testing, but I don't utilize that to make therapeutic decisions. IDH mutations can stay present for a long period of time with no active disease. And then that just gives me something to kind of else to worry about. I follow it, but I don't make.
But you don't,
I don't have
transplant, and Alice, same? Is that same? Yeah. Yeah, I mean, a lot of them, we're starting to see may also be CHIP mutations, right? So these may have been there for who knows how long before. And yeah, the same thing. We make no changes in our treatment or de-escalation of treatment if the IDH is present. Because post-transplant, we're seeing a lot of patients where that's like the one IDH or TET2 are the mutations, or DNMT3A. And usually I'm like, okay, that's fine. I'm not going to change my management or maintenance based on that. So,
and if you recall, we had that debate maybe on a few patients. So if they're like NPM1 IDH and the IDH persists and we're back to transplant or not, If you look at the Othman paper somewhere in the supplement, the IDH mutations have a higher risk of relapse.
Right.
So they can be salvaged, but they have a much higher risk of relapse. So if we go back to this, debate about transplant, and you have a very good candidate, this helps me push more towards transplant, and that's how I would use the IDH mutation detection in this case.
That's a good, so the NPM1, exactly, very good point, Gus, that there were data and it's buried because we always, focus on the high level, but IDH, WT1, DNMT3A, and if you had more of those, then again, even if they achieved a deep molecular clearance, it may not be the same. And this is not unique to AML. In ALL, where they are much, much, much ahead of us, we're finding things. If you have ICROS mutation and you achieve molecular clonoSEQ negative, the outcome is still not as good as those. So the point is, we have these debates and things, like, okay, is it phenotype versus MRD? Like, is this the destiny if you have these mutations or not? And it probably is a combination of both, that if you have bad mutations, even if you achieve good molecular clearance, you may still never get to the same level of cure and transplant may be needed. And in some of those that do not have bad mutations, maybe MRD is more relevant. So I'll turn it back to you, Alice, to close this out.
Yep. So just to recap, for upfront therapy and IDH1 mutated AML for our 66-year-old patient with newly diagnosed IDH1 AML with a performance status of 2 and comorbid renal dysfunction. So IVA-AZA, supported by the phase 3 data, NCCN guidelines, is a reasonable lower intensity choice in this patient with comorbidities. You could also consider Ven-AZA. You may want to more strictly look at tumor lysis monitoring with the renal dysfunction. For the patient with a performance status of 1 and no major comorbidities, intensive induction is reasonable. We're awaiting future data, as mentioned, on the addition of IDH inhibitors to this. And then lower intensity options could also be considered based on patient preference, goals of care. And so for our patient, when she relapsed with her IDH1 mutated AML with a performance status of 2 with prior therapy with AZA-IVO, one thing for any patient beyond this IDH population is really important to retest for mutations. Just because you can have clonal evolution, you can have loss of mutations, gains of mutations, and you want to be sure you have the most updated data to make treatment choices for your patient. So for that patient, both ivosidenib and olutasidenib are approved and recommended by guidelines in this setting. Given prior IVO exposure, sequencing to olutasidenib is an optimal next step. For the patient who had prior therapy with AZA-VEN, current evidence suggests olutasidenib is an effective choice in this post-venetoclax setting. Ivosidenib could be considered as per guidelines, though there's not as much efficacy data in the post-venetoclax or for post-venetoclax treatment.
Is it worth mentioning for Susan if after she's had AZA-IVO, thinking about a Ven-containing regimen as another therapeutic option?
Yeah. I think the data is more limited for that specific scenario, but I think a lot of people do that in clinical practice, so that's a very good point.
Okay, so before we go, let me ask you all a little bit of a provocative question. So we talked about this, but we kind of like skirted the issue. So if you have somebody with AZA-VEN failure with IDH1, olutasidenib for everybody, ivosidenib for everybody, or is there something to select? Now let's assume they don't have LFTs and all, but healthy patient, post-HMA-VEN, the oluta data is good. I mean, we're seeing more and more. Would you just use oluta, or why would you use IVO? Because this is the question, we always discuss in our group. If the CRH is looking better, now many people are getting frontline IVO, so that's a different thing. But in salvage, how would you choose? Maybe Alice, Jessica, Gus, all your thoughts?
I would do either. I don't think I have a...
So we're saying we don't believe that CRH is really that different?
No, the CRH,
tricky.
The CRH is great.
It's much better, right?
In that context.
Yeah. But we think that they're equal because, I mean, it's your patient right in front of you. Like, what would you say either is okay? Or would you say, I like this? It's like the quiz and Mito question, right? Neither is wrong. But we feel that there may be more data with one, or no, we think it's too early.
Okay, I'll answer.
Yeah.
I think it's probably too early. I think there's not that much data, but with the data that we have, with the patients that I have had in this situation, most of them, there are not that many in this situation, most of them have chosen olutasidenib.
I think we need data with IVO in that
Yep,
setting. And that's a big gap, right? So that
Big missing
because
gap.
that's been like a 5-year period. So we need some data there because otherwise I agree with Jessica. Like if there's only one data set, then that is the data set I have to use to guide my patients. Otherwise I'm making a guess versus data. So I think that data is very, very critical. There are many studies coming, I think, with Oluta, so we will see. And maybe it won't matter because upfront, if we start using the triplet, then in the salvage you have to use Oluta. But I think somehow that data is still not there with IVO in the post-HMA event. So we need that. Okay, with that, I'll turn it over to you guys.
Okay, I'm gonna talk to you about menin inhibitors. So this is Christina. She's a 52-year-old woman with de novo AML. Initial NGS shows no FLT3, no NPM1 mutations, but on cytogenetics, there was a translocation 911, so KMT2A MLLT3. By the way, the names of the genes keep changing, so this could be confusing. It used to be called AF9, now it's MLLT3, but it's translocation 911. So she had 7+3, had a CR, but relapsed at 14 months. So keep that case in mind. I'm going to talk to you also about Scott. He's a 60-year-old man with de novo AML, normal karyotype, and NPM1 mutated. He was not at his best when he was presenting. He had a little bit of decreased performance status. His lung function was not great, so he was considered not fit for intensive chemo. And he got AZA-VEN. He did get a CR, but eventually relapsed at 10 months after that. And at relapse, he did have NPM1 mutation confirmed. He received FLAG-IDA salvage and had limited response. So the questions to think about: what is the role of menin inhibitors in each of these settings? What is the role of combination therapy with menin inhibitors? And is there any future of menin inhibitors as upfront therapy? Just one thing I would highlight from these cases about 911, if you look at the ELN, it would say it's intermediate, but I think that data reflects younger patients, so age less than 60, who had high intensity chemotherapy. So in my practice, and more evidence, there's data from our center, there's data from Harmony, all KMT2A rearrangements have adverse prognosis. So just because the ELN puts it in intermediate doesn't make this, the difference is marginal. So the switch should still be a patient that should get the stem cell transplant. Before we talk more about menin inhibitors, I'm going to talk to you about KMT2A rearranged leukemias. These are targets for menin inhibition. This is a graph where I try to show the representation of KMT2A across various ages or phenotypes. So roughly, KMT2A rearrangements occur in 5 to 10% of acute leukemias. They are more common in younger patients. So young adults will have a higher proportion of KMT2A rearranged leukemias. And for example, they form 80% of infant leukemias. These would be leukemias occurring in children less than 2 years old. So roughly there are 7,000 cases as global incidence. And the common thing about KMT2A, regardless of the phenotype, ALL, mixed phenotype, or AML, is that it's a therapeutic challenge because it's resistant to therapy and has high risk of relapse. Overall, the 5-year overall survival for adults is less than 25%. Now, about NPM1, we all know the data about NPM1 in frontline. So this is considered a favorable risk cytogenetics, but that doesn't mean that at relapse this carries the same prognostic value. So this is work that I've done with Naval from our data set at MD Anderson. So any patient who's relapsed with NPM1 and you compare their outcomes to anyone who's also relapsed but NPM1 wild type, they have the same overall survival. In other words, just because they have the NPM1 doesn't make them do better. The good ones are already in remission. We've selected for the ones that have higher risk of relapse and their outcomes are the same. There is a benefit of venetoclax in NPM1. We don't understand the science of it really well, but across multiple data sets from the VLEA, from MRD data, NPM1 mutations respond really well to venetoclax. In our cohort, in salvage treatments that contained venetoclax, NPM1s did better compared to those patients that didn't get venetoclax. So there are multiple menin inhibitors currently in clinical development. So revumenib is the first menin inhibitor to be approved for KMT2A rearranged leukemias in adults or pediatric patients aged more than 1. Ziftomenib is currently under investigation, but recently submitted for NPM1 for FDA approval. And Blexi and Zomenib are currently also in clinical trials, and they're further along now with phase 1, phase 2 clinical trials. Okay, so these are the NCCN guidelines on currently what's approved, and you can see that revumenib is considered in the NCCN recommendations for KMT2A rearranged leukemias. And this is based on the Augment 101 clinical trial. This was a single cohort or single arm cohort for KMT2A rearranged leukemias. So it's AML or ALL. It included children and adults. The total efficacy population, and this is a pooled analysis beyond the interim analysis, was 97 patients. And the CR/CRh rate, so complete remission or complete remission with partial hematologic recovery, of roughly 23%. These patients were heavily pretreated, and they achieved this response rate. The expectation of these patients, if they had gotten chemotherapy and not revumenib, would have been less than 10% chance of response. So that's why this was considered a therapy that deserves FDA approval. So the median duration of response was 6.4 months, and I'm going to talk to you more about this. This could have been related to development of MEN1 mutations, which indicate on-target effect of the menin inhibitors, but also tells us that maybe we need to use combinations, or we need to use menin inhibitors in earlier lines of therapy before there's much more clonal evolution and chance for resistance. These high rates of remissions occurred regardless of prior transplant or refractory disease or prior lines of therapy. Maybe the ones that had 1 or 2 lines of therapy did better than those that had 4 lines of therapy, and maybe some effect of prior venetoclax. So this is the results now of revumenib with NPM1 mutant acute myeloid leukemia. This is the same study, but a separate arm with NPM1. And the response rate is similar to KMT2A, with a CR/CRh rate of 23%, an overall response rate of 47%. These are the swimmer's plots of patients. The duration of response in this case was, duration of CR/CRh was about 4 months. So more to be done in combination or using revumenib in here with other combinations. Interestingly, from that study, when we look at co-mutations, these are small numbers, and try to see any predictors of response, the only factor that predicted better response to menin inhibition is a co-mutation with IDH1 or 2. And I'm going to give you Dr. Wang is going to present this in the ziftomenib data, and that's the same that was found in ziftomenib. She's going to present it this ASCO. And I found interesting that there was a preclinical paper published in PNAS last week that had an NPM1 IDH model and showing similar results. So I'm curious about this now that it's in 2 data sets and in some preclinical data that supports it. I don't know the explanation for it. So this is the data from the menin inhibitor ziftomenib. So ziftomenib monotherapy is focused on NPM1 mutated acute myeloid leukemia. The phase 2 arm met the primary endpoint, had a CR/CRh of 23%, and had a similar duration of response, about 4.6 months. These were also patients that were heavily pretreated and achieved those remissions. So I think these results would be promising. Dr. Wang will be presenting this data on Monday. The next steps in any targeted therapy, I mean, if you take any targeted therapy in cancer, EGFR inhibitors, KRAS inhibitors, BRAF inhibitors, are going to be combinations. We tend to use these targeted therapies in people who are heavily pretreated, and we expect to get them in cure. And the reality, we all know it, that we need to do combination therapies. We need to combine them in earlier lines of therapy. So I'm going to take you through some of the data on that. This is my favorite trial. This is the combination of revumenib plus ASTX, which is oral decitabine, plus venetoclax. And in this, we did a phase 1, phase 2. Just some slight things to note is that the venetoclax, for example, here is for 14 days and it's fixed. And the revumenib duration would depend on the day 14 bone marrow biopsy. I had presented these results at ASH, and this study is still ongoing at MD Anderson, and we have very good response rate in relapse refractory disease. So the overall response rate reaches about 82% with a CR rate CR/CRh rate of 48%. We had deep remission in these cases when we did MRD by flow, where 88% of cases with CR/CRh had MRD negative remission. Half of the patient were able to go to transplant. So I think with this combination, we are improving on monotherapy and improving durability of response, but obviously we need longer follow-up and more patients, which we're working on at the moment. These results have been replicated with other menin inhibitors as well. This is the combination of ziftomenib plus AZA plus ven. I would say that BCL2 plus menin inhibitors has excellent preclinical data and now has very robust clinical data that is showing in multiple cohorts. So I think among my favorite partners with menin inhibitors, I think venetoclax really improves outcomes because it's a dual differentiation plus apoptosis effect that is driving better remissions. So this is also data from bleximenib, the menin inhibitor from J&J. There's a similar CR/CRh rate with smaller numbers with KMT2A and NPM1. And so far, the combination with HMA and ven is well tolerated. I didn't talk in the previous slides about differentiation syndrome. So in monotherapy with menin inhibitors, the chance of differentiation syndrome or grade 3 differentiation syndrome is roughly between 10 to 15%. Just like what Dr. Mims was saying, it's very important to give steroids as soon as you suspect differentiation syndrome, and that would help mitigate it. The menin inhibitor revumenib had QT prolongation. Other menin inhibitors, for example, here, bleximenib, did not have effect on QT prolongation. So the other menin inhibitors that's also in clinical development is enzomenib. Dr. Daver has been heavily involved in developing this drug. So there were, in this study, they presented results with and without azoles. They're currently investigating, just like we did with revumenib, whether there's a CYP3A effect on the drug. And so far, the effect on the levels of the drug seems to be minimal. They did not see severe QT prolongation. They had differentiation syndrome roughly about 10%. We're going to show more data, I think, in the future about this. And just like with the other menin inhibitors, we have excellent response rate. The CR/CRh rate is roughly 30% in KMT2A, about 47% in NPM1. So overall, this is the same theme about these menin inhibitors showing robust data sets or robust data across genotypes and across menin inhibitors. So what is the evidence for using a menin inhibitor in the first-line setting? So far, these are all clinical trials. They're phase 1 clinical trials. So we have to understand the data in that context. It's a little bit easier to interpret the data for KMT2A, and it's harder to interpret the data for NPM1. So for KMT2A, we know that they don't do very well with AZA/ven or with high-intensity chemotherapy. So when we see improvement, like for example, from the data from Beat AML here, the response rate almost reaches 100%. We know that this is an important improvement for KMT2A. For NPM1, it's a little bit more tough to see if we move the bar, because if you think of AZA/ven and response to NPM1, it could be between 80 to 90%. So to learn more if those results are holding up, we're going to need either deep MRD assessment, where we have MRD negativity rate that surpass HMA/ven, or we have a longer duration of follow-up where we see hopefully improvement in survival. But regardless, the theme that I would take again is robustness of the data. This is the data from 7+3 in combination with ziftomenib. This is mostly focused on NPM1. It also included KMT2A. And the response rate is great. 24 out of 24 patients had responded and remain alive. And a lot of them ended up in transplant and are getting ziftomenib maintenance. So for a start, for menin inhibitors in combination with either high-intensity chemo or low-intensity chemo, I think we're off to a great start, but we need more data, and that's why the randomized trials that are planned are going to be important. So similar results have been seen with bleximenib in combination with 7+3. An important thing to highlight across these menin inhibitor trials in combination is that the rate of differentiation syndrome was less when given with combination, either chemo or HMA then. This is the same that happened with IDH inhibitors, or even, atraarsenic with a little bit of IDA that cuts down the rate of differentiation syndrome. So I think, moving forward, when we use these agents in combination, the chance of differentiation syndrome is going to be less. I would still be very vigilant about it and give steroids as soon as you suspect it. In combination with 7+3, very high response rate with Blexi, a composite CR of almost 86% in KMT2A and in NPM1. So practical points about all these medicines. So I'll tell you the way I consent my patients or how I'd approach menin inhibitors. So first of all, about dosing, revumenib is affected by CYP3A. So just like venetoclax, you have to be mindful of what azole is used with it, and then you adjust the dose based on the azole use. So posa or vori, you would use 160 milligrams twice daily. If they're getting no azole or any other azole, such as Cresemba or fluconazole, they get to 7 milligrams twice daily. And for pediatricians or young adults, anyone whose weight less than 40 would have a BSA adjustment to the dose. Ziftomenib is a fixed dose, 600 milligrams once daily, and that's for NPM1. Blexi, I think we have an RP2D now. It's 100 milligrams BID with a step-up dosing. And enzomenib, I think we have an RP2D. It's 300 milligrams BID. So the part that I tell my patients about menin inhibitors, I tell them about on-target side effects and off-target side effects. And the things I tell them first about are differentiation syndrome, and I explain it to the patients because I want them to recognize it themselves and even sometimes tell the ER doctor that I may be having differentiation syndrome. And I tell them about the risk of dropping their counts. I think it's not very clear with single agent menin inhibitors of having myelosuppression, but when we use it in combination, it's possible that it leads to myelosuppression. And then depending on the menin inhibitors, I may tell them about other side effects. So for revumenib, I tell them about QT prolongation, tell them that I'm going to monitor the EKG, and I'm going to make sure that their potassium and magnesium are regulated. With ziftomenib, there's possibility of itching. I warn them about it, but it's usually well controlled with any medicine, Atarax, for example. For Blexi, I can't tease out yet specific side effects. It has the common side effects of differentiation syndrome and possibly myelosuppression. For Enzo, I'll defer to Dr. Dav. I don't think we had anything specific for Enzo. Maybe the drug-drug interaction is still being sorted out, but nothing specific. So back to the cases. So Christina, which was the 52-year-old that had the 9/11. Maybe a question for the panel. I already ruined it. I think I talked about it before. What are the prognostic implications of KMT2A in this case? Naval.
Yeah, I mean, that's great. First, thank you, Dr. Isa, very much for a great talk. And yeah, I mean, so, I think in general, as you said, the KMT2A is kind of an aggressive phenotype. They often present with DIC and elevated white count, organ infiltration, and I think should be considered as both a high-risk phenotype as well as a targetable aberration. So that's kind of very similar to FLT3, it has a high impact prognostic value as well as a targetable value. So that's how I would look at this. Of course, as you know, every patient that we get, we're screening them now both by FISH as well as RNA fusion panels to see if we find some of these cryptic KMT2A rearrangements as well as others. But yeah, I think this would make me think very early on of a menin inhibitor-based therapy, both frontline and in salvage setting. Yeah.
What about the NPM1 at relapse? Maybe Dr. Altman.
Sure. So NPM1 mutated AML is only favorable at newly at diagnosis. When disease relapses, it's no longer favorable because the disease has relapsed. So I'm in my NPM1 mutated patients am recommending clinical trial with a menin inhibitor in combination.
Do you guys always recheck mutations when someone has NPM1 and they relapse?
Yeah. NPM1 is more likely than FLT3 to always to be present at diagnosis and relapse, but needs to be rechecked.
I think we had this debate because of venetoclax.
Yeah, I mean, I think this is going to change a lot. It's very interesting, and I think Tapan has shown some of the data, but it'll be published. So, with FLT3, it was kind of like when you used the single agent FLT3 inhibitor, there was about a 15-20% loss. And then with intensive chemo upfront with MIDA was almost 45-50%. With quiz, the data is not there, but my guess is going to be higher. Australian group has shown that sorafenib also 50-70% losing it. And then with IDH was the same. Initially, we saw very little IDH loss with single agent IDH inhibitor, but now Courtney and our group have shown with the triplet close to 50% are IDH negative. And with the NPM1, it's the same, that when you had non-targeted therapies, it was very rare to lose NPM1. With the menin, we started seeing a few, and now with some of the combinations with Clea-Ven or the menin-Ven, we're seeing more and more. So I think the bottom line is, again, it's very thematic that if you have powerful targeted therapy in combination, synergistic, you're probably going to hit that clone and get rid of it. But eventually, unfortunately, now it'll improve your duration of response and survival, which is good. But eventually, the other clones are coming out. And so that's where we have to either track them and intervene at an MRD escalation point, or have broader combinations or sequential approaches, where how we do in ALL, where you sequence the different agents so those clones do not get a chance to escape. But I think it's going to be very interesting how things evolve.
So what if the Scott is 60, had 7+3 with NPM1 and just relapsed? Ask my colleagues, would you do high intensity chemo then salvage? Would you do a menin inhibitor salvage if they're approved?
So just to recap, 70 got 7+3 and still has an NPM1 mutation. So our institution, we would offer him a clinical trial. We have both high intensity and HMA-Ven based studies with menin inhibitors. I anticipate that after a conversation with the known venetoclax sensitivity with NPM1 mutated disease, that he would choose with, our input, would choose likely an HMA-Ven menin inhibitor study, because I think the response rate is high with the anticipated stem cell transplant.
Yeah, we used to debate. I think when we had a single agent menin and a FLAG-IDA-Ven, there was a lot of debate, and the FLAG-IDA-Ven data is strong, about 60-70% response even in this setting. But I think now with the combinations, it's equal or better. So I think the more interesting question would be, what if they had HMA-Ven, right? And then there's 70, and now they relapse. So what do? Do you give single agent menin? Do you give HMA-Ven menin and still think, okay, you're going to overcome it? Or do you do intensive chemo menin? So what are your thoughts?
Yeah, we're going to be talking about very small numbers. So on SAVE, which is the HMA-Ven menin, there were half that had HMA-Ven, and the previous exposure to HMA-Ven did not affect the chances of CR, CRh. Can't tell yet if this is some hypothesis about sensitizing, like menin inhibitors sensitizing BCL2, or is this heavy lifting by menin inhibitors and maybe some other clones that are dependent on BCL2? I mean, the data on triplet looks really
still good, yeah. So we'll have to see. We saw this with Jessica and you, the Ven Guild, and we had patients on HMA-Ven, and the response was good, but the durability was less. So we'll have to find out, how that plays. But yeah, there are going to be a lot of different options there. Yeah, I think the question is really going to be, can you use menin inhibitors sequentially, and will they work, right? Because we say like CML, for example, if you use imatinib and you have a particular resistant E299 or whatever it may be, then you can use dasatinib. And then if you have T3159, you can use ponatinib and olverembatinib. So is that going to be the story with the menin inhibitors, that, okay, if you have an M327 on revumenib, that's fine, you can use Blexi-Enzo. But then if you use Blexi-Enzo, then we know there are other unique mutations that Scott Armstrong's group has shown, then can you switch? Or is it that in AML, once you become resistant, it's probably going to be difficult to really salvage with a menin inhibitor? What are your thoughts, Gus, or others? I know you thought about this a lot.
If this is, if MEN1 is the cause of resistance, I think it's reasonable to switch to another menin inhibitor. But we still don't have a lot of data on that.
Any other thoughts, Alice, or
Well, I was just curious
Jessica?
if you have a commercial test or something you're using to test for MEN1.
You want to elaborate, Gus?
Yeah.
Blood, sweat, and tears.
Not commercial, but
Not commercial. So we've been working on a ddPCR assay for the past, year, and I presented it to 6 committees, and maybe it will get approved.
yeah.
Yeah.
Are you checking for this, Jessica, the resistant mutations, or checking
We're
it out, or?
we're not yet. And I think, I think we just don't have data yet. Your original question was, are we going to be able to sequence, or once you're done with menin, you're done with menin? I think they're two different patient populations, right? Those who don't respond at all to a menin inhibitor, or versus those who respond and then relapse. And I think the resistance mutations are likely to be different.
But what I used
don't
for my committees is like
Yep.
the Wallace Bourgeois from Armstrong's lab had very good data presented at ASH, and he's gonna publish it soon, where he did that's what Naval was talking about. He did like a heat map, just like in CML, with IC50s of each different drugs and different mutations. So I think that may be an argument for checking MEN1 mutations.
Oh, I agree. It should be done. It's just not as commercially available at
Yeah.
even large academic centers.
But I also think, because even if you look at, let's say, FLT3 quizartinib, remember the TKD emergence was a big problem, and as everybody thought this will be the problem like 8 years ago. But then as we combine it with intensive chemo, and we have done a DAC-VEN, that is not the problem. We almost see no TKD. Now everything else is RAS, clonal escape, BCR-ABL in a few patients, JAK2, and with IDH, again, the same thing. We're seeing that we used to have these hotspot IDH mutations with single agent. Now with combo, it's not that. It's more clonal escape, proliferative. So I think as we move to the combinations, we'll probably hit the menin well. There will be few, but I don't think it'll be the dominant mechanism. And that it'll probably be either, loss of epigenetic regulation, or there will be clonal escape, and the usual bad RAS players will start coming in. So then we'll have to see what combinations we can develop. Yeah. So we do have a few minutes. We can do a couple of questions here quickly. The one thing we didn't talk about at all on purpose probably was TP53, but there's a ton of questions coming in about TP53. So let's take one of them. Any progress in treating TP53 mutated AML? Have you personally changed the way you manage this subgroup of patients over time? Alice, TP53 AML, what do you do?
Yeah,
Young, old?
Yeah, that's a great question. So I think for most patients, I do an HMA-based approach. In some cases, I'll add venetoclax if you're trying to get patient to transplant, just because of that increased response that may get them over the edge. And I still do advocate to transplant patients, just because there's not great data that all TP53 mutated patients are going to relapse post-transplant.
Yeah, it's a tough group. I mean, we do the same, for most older patients, we're doing HMA more and more alone even, and trying transplant. We may do the first cycle with VEN just to kind of boost that response. Intensive chemo pretty much for the real TP53, like the high VF complex karyotype, we have stopped doing for the most extent, unless it's a last minute, last ditch 30-year-old, you have nothing. I mean, we're going to try it, but yeah. And that's the other question somebody asked, is there a importance of knowing the VAF on TP53, or is it just enough to know if the mutation is there or not? I would say to that, yes, the VAF does matter because there is a small subset, but important subset, about 15% of TP53 that have low VAF and no associated adverse cytogenetics who can actually do well, and we treat them as a non-TP53. Maybe it's a subclonal mutation and it's not driving the leukemia. So you do want to know, we actually always ask, that's the first question we ask, what is the VAF? Are there multiple TP53s? And is there associated cytogenetics? And if the patient's lucky, they may not have those features. And then maybe the last question here will say, which is a very interesting one, I think, and I'll ask Jessica to give some thoughts. Are the new ELN prognostic criteria for low-intensity AML treatment applicable here in U.S. practice? And if so, how?
So I think the gene modifiers, the 4-gene panel, I utilize that when I'm looking at a patient in front of me and trying to sort out what I think their response rate is. I think kind of taking a step back from that question, it's important to note that the prognostic scoring systems that have been utilized in AML are based on younger, intensively treated patients. And so we don't know that the data regarding prognosis applies to patients who are treated with HMA-VEN or cladribine, lodoserosine, venetoclax. I mean, we've made it, an hour and a half without talking about cladribine, lodoserosine, venetoclax, guys?
It's a great question. Next time we'll have a whole session on that.
Right. Yeah. So it's important when you're counseling a patient and when you're thinking through the patient yourself about what was utilized to come up with that prognostic scoring system.
Yeah. No, I mean, I think I agree with you. Like on a patient by patient basis, does it matter to me? Not really. Like my selection is more on, is there a target? Is there a KMT2 NPM1 FLT3 IDH? Can I add something? Yes or no, right? But I think it actually is going to help us a lot in trials because a lot of trials are using that 17 or 16-month magic number and say we're going to beat that. That's actually not true. For NPM1 without FLT3, we're looking at 35 months. For KMT2A, it's probably even less, 10 months. For FLT3, it's at 12, 13 months, as you showed. So I think it will help us a lot when we design trials to know what is the expected outcome for that mutational group for that. So I think it's a good effort, and data is always helpful. But thank you all very, very much for coming, and see you soon. Bye.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the HealthTree Foundation for Acute Myeloid Leukemia. This activity is supported by educational grants from Astellas, Daiichi Sankyo Incorporated, Johnson & Johnson, Kura Oncology Incorporated, Rigel Pharmaceuticals Incorporated, Servier Pharmaceuticals LLC, and Syndax. To access all materials for this activity, visit peerview.com/KEE860.